Again. Hello, everyone. We're just getting the slideshow up, and there we go. Is that good? Okay. Well, great. Welcome, everyone, to the webinar. Thank you so much for taking time out of your morning. I can see some of you, but if you want to uncover your video, that's fine. I will be referring to my slides, but I'll also be waving my hands around somewhat so that we can go through this experience together. So I want to thank all the sponsors of today's webinar. And as Jody said, I'm a positive approach to care trainer. I do have a website, dorothycolby.com. That's where you can go to find out about my workshop series. I do have one on this very topic. Today we're doing an hour's worth. I'll be doing the same topic for 2 hours and much more physically interactive. So if any of you are on Oahu or happen to be on Oahu for the weekend of November 10th, you're welcome to come and join me for that. You can email me. I'd be happy to give you a free admission, kind of a special bonus for attending this one here. So it's dorothycolby.com there. So today's topic, the end of life and letting go, providing care in the final stages of dementia. This one is, I would say, one of the most difficult topics in some ways, but it's one that's really very close to my heart because so many of us have been caring for, whether it's our own family member or if a lot of us are professionals, have our own family members plus the people we care for professionally. It's been a very, very long journey, and we're talking about one of the hardest things to accept because one of the things that's a challenge is when someone gets a diagnosis of dementia, you're in the doctor's office and say your mother has early signs of dementia, or your mother has had a stroke and now has vascular dementia. Dementia is a terminal condition, and it's very hard for us in that moment to think of it as terminal because they look the same. You're noticing changes, but they're looking the same. And so how can this be a terminal thing? And it can be even harder sometimes as the disease progresses because we start having those frustrations, and it seems so terrible. My mom just keeps asking me the same questions over and over and over again, and this is so bad. This is like, God, her dementia is so severe. This is my, oh God. But I have to call a timeout there because that stage, the repetitive questioning, the one that we're all so familiar with, is actually on the earlier to mid stage. We're not near the end yet, and it is such a long journey that can be really, really hard for people. So I want to talk about a little bit why dementia is different as the end of our life journey approaches, because we all have an end to our life journey, and there are many different diseases or disease processes or things that bring us there. But what is so different about helping people and families who are living with dementia to get to the end of this journey as positively as possible? And number one is it takes a long time. By long time, they say the average is 8 to 12 years, but it could be 2 to 30. And that's just the average. So in from my own personal experience, my grandmother had Alzheimer's disease, and she's the woman who raised me. And so I was very fortunate to see her through her full journey of dementia. So, I knew her when I was young, when she didn't have any dementia, to the very end of her life when she passed away due to Alzheimer's disease. And when I look back on her journey, she, in hindsight, of course, at the time I didn't know anything about dementia, but this was just a normal part of aging. Oh, grandma's just getting forgetful. That's what happens when you get old. But in hindsight, she probably started showing signs of dementia about 1984, 1985 at the latest. She didn't pass away until 2001. That is a very long journey. And the person changes and changes and changes, and you might feel that you've lost the person, even though they physically are still there. But we have changed too over the journey. Over 10 years, if you think of yourself 10 years ago, are you exactly the same as you were then? Have certain things changed about you, aside from, maybe some gray hair or things like that? But in terms of your experience and your outlook, think 20 years back. So we change, and how we interact with the world affects that over time. So our person who is living with dementia, and those of us all around them who are caring for them, we're all changing through this journey. And so a lot of times it's hard because we think back on how they were, and it's hard to see them as they are. So I want to try and think about, let me go back one more slide, about how we can stop and take a look at who they've changed, but they are who they were, but they're different, and how we can meet them at every step of this journey, join with them, and see what remains and how we can connect, and what works and what doesn't work. And so that's going to be the focus of today. By the way, if you have any questions throughout this, if you want to put them in the chat, is that right?
Yep.
Jody, you're welcome to put it in the chat, and Jody will pass them on to me. And I will be leaving about 10 minutes at the end for a question and answer so that we can answer them live. So I'm not going to spend too much time on this part. I know many of you are healthcare professionals, but we want to look at what all the things we need to have in place. Now, this is not just for people living with dementia. This is for all of us. But in terms of thinking about people with dementia, I'm going to focus a lot on palliative care today. So we'll be going into that. So I want to take a step back even further before we even reach the stage of palliative care and think about what are the different care approaches that we have at our fingertips, that we have to choose from, and which one of these we choose when in the course of dementia. So I want to start with number one, health promotion. So I want everyone to think for a second. If you have a pen and paper, this is the interactive part, you can jot down for yourself. So health promotion, these are things that you make a choice to do to help improve your health and overall well-being for yourself. So think a moment for a second. Think about two things that you do for yourself actively for your own health promotion. Just think for a second and jot them down, okay? I know you might think of more than two. Okay, so here's some examples of things. You go for annual checkups. Has everyone gotten their flu shots? By the way, it's flu season, right? We focus on the numbers, and what are those numbers we want to lower? Maybe everybody in this room can shout them out too. What are the numbers? Weight, blood pressure, cholesterol, right? All those blood sugar. We're focused on the numbers to help. Those are things that we do. If we can have those be at the optimal level, that is part of our health promotion. Increasing the activity level, eating well, right? Eating right, eating moderately, right? Monitoring conditions you control. Let's say you have diabetes, monitoring your diet. It's doing what you should do to be the best you can be. Now, we all know these things, but how good are we at doing them? We don't have dementia. How many of us haven't gotten our flu shots yet, right? How many of you have skipped your checkup this past year? It's perfectly normal, but health promotion is something that does take work, and none of us are perfect at it, of course, but this is something that this investment of time and effort pays off in the long run. So changes that we can make now, getting, for example, getting a flu shot, can help me possibly not get the flu this year or get it a little less severely. So there's a future payoff for this kind of health promotion, because I have, fingers crossed, a long window of life ahead of me. If I keep those numbers in check, it might pay off for me down the line. So this is a future-looking health choice that we're doing. So then the second one is curative. So curative is things that we do. Let me go here. When something's wrong, we get to fix it. And our medical system is very well set up for this curative step. So if something is wrong, if I fall down and get a big gash on my head, I can go into the ER, they can stitch it up, boom, I'm good to go. If I break a bone, I can get it set, and barring anything extreme happening, I can be back. Something happens, I have a drop in function or a drop in some other thing in my physicality, I can get back to where I was. It's about surgery, medications, and treatment, and the expectation of this is I'm going to have a full recovery of function. I'm good as new. here's where when we're working with people living with dementia, actually the first one plus this one, where getting to good as new is not so easy anymore. That there are things where you might have, let's say, if I have a UTI, a urinary tract infection, I have the full expectation, when I go in, I'm going to get my antibiotic, it's going to be cleared up, and it's not going to come back if I take care. But when someone's living with dementia, that antibiotic is not going to have the same effect. It may clear it up now, but they'll have repeated UTI after UTI after UTI because the changes in the brain, the gradual brain death is affecting their immune system. So the ability to have something that used to be curative anymore is no longer true. So that's a change for living with dementia. The next stage, I'm going a little bit in and out of focus here, so please excuse that, is restorative. So we accept that, okay, something has happened, I've had a fall, and I might not be able to get back to where I was, right? Not perfect, but I'm better than I was. So that might be, I fall and I break a hip, and I might need some extended PT to get me back to something close to where I was. So the focus is on regaining skill and ability. So things like rehab, physical therapy, special equipment. Now I need to use a walker or something like that. New techniques. I need to, okay, now Dorothy, when you stand up, don't just stand up. Make sure you get to the edge of the chair. Okay, put your hands there, okay, and make sure, okay, and then wait now. Hold on there for a few seconds. All right. So there's a lot of steps. And the key part of this one that's a little different is I need to remember. I need to be able And so with people living with dementia, forming new short-term memories, learning new skills, while not completely impossible, very, very hard. So I may fall, I am a person living with dementia, I fall and break a hip. Someone in my same position without dementia might be able to go through rehab and do all those things to get back to close to what level I was. But I land up in rehab and I'm like, no, there's nothing wrong with me. Let me out of here. No, Dorothy, you broke your hip. No, I don't know what you're talking about. I have no memory of ever breaking my hip. I don't know why this is hurting when I try and stand up, and I will not participate with rehab. And it's very, very frustrating because we want this to work. It used to work, and it's not working anymore. So what can we do? Okay, I'm going on to the next one, maintenance. So you can kind of see where the scale is going here. This is about, okay, I know we're not going to get back to where we are, but let's just try not to lose any ground. Let's just kind of do everything we can to adapt to maintain this level of function. So what that depends on is the physical environment not changing. So I'm going to get everything arranged just so, going to have the consistent caregivers. And it depends on me not changing. Right? And everything else staying the same. And as we talked about in the beginning, dementia is a progressive, degenerative, terminal condition. The person living with dementia, I cannot help it. I'm going to keep changing. I didn't ask for this. I didn't want this to happen, but it is happening, and then my disease will be progressing. Caregiver consistency, even if the caregiver is the same one, a spouse, a child, a daughter or son at home, we're not the same minute to minute. I might have all the patience in the world in the morning, but by 5 o'clock, when my brain is tired and you've been asking me the same questions all day, I'm not going to give a consistent answer. You've asked me that 100 times. And it's not because we're bad people. It's because we're just human. We cannot maintain that consistency without help. So one person, if you're sitting if you're in your office, people won't think you're crazy. But if you put your thumb up like this, when one person has dementia, everyone around them is affected. Everyone has dementia. We're all in it together, and you cannot do it alone. Whether you're a professional caregiver or a personal caregiver, you cannot be the Lone Ranger. I know that's kind of an old reference for. I don't know if young people even know who the Lone Ranger is, but you can't do it by yourself. right? You need a team. So many of you are at workplaces, and we have professional teams that might be able to help us with our client or patient that is doing that. But when you're helping those families and that person living with dementia, they need a team on their part too. So it takes all the stakeholders working together. And it's hard work, so hard work, because it's really impossible to keep things exactly the same. It's just not, it's not doable. So we have to figure out what is worth trying to maintain the same, and what things we need to let go of, that we have to accept that are going to change. The next one is compensatory. So this is when we're just trying to fill in the gaps, just so we can, this is related to the previous one of maintenance, but filling in the gaps so life can go on. So a lot of them are supportive things that we do to replace the skills that the person living with dementia have lost. So if you put your hands up like this, out there, and these 3 fingers here, these 3 fingers, 1, 2, 3, these are your skill fingers. And if you think about, like, if you pick up your pen, which 3 fingers are you primarily holding with? Those 3. You're buttoning your button, right? Putting on your glasses. These 3. These are your skill fingers. These 2 fingers here are your strength fingers. You can make a fist like this. If you were holding a hammer like this, squeezing pliers like this, these are your strength fingers. Skill versus strength. With all dementias, you learn skill first, but you maintain strength. So as I'm having trouble using these manipulative fingers, now you don't just have skill in your fingers, you have it in your eyes, you have skill in your hearing, feet, right? All those things start to diminish. We make changes to help compensate for that. So I'm no longer able to hold this spoon correctly, so you might get me an adaptive spoon that I can hold with my strength fingers and still be able to feed myself. I'm having trouble walking, my balancing, my skill on my feet is bad, so you give me a walker and help me try and learn to use that. You'll probably have to give me a lot of cues reminding me that I have a walker, right? Telling me where I've got it backwards, flip it around for me. I've had people, and you've probably seen it, walk around carrying their walker in midair. Again, it's going to take some cueing to remind me where the walker is supposed to be on the floor. Right? So we try and fill in all these gaps so I can maintain my function. I can still eat and feed myself, and I can still walk. And we adjust the schedules and routines to accommodate. So, but the end point is the same. Things keep changing. Things keep needing more adaptation. So this also is a struggle. After a while, no amount of telling me I have a walker is ever going to make me use my walker. And so then what do you do? Because you can't rely on this compensatory support anymore. And that brings us to palliative care. So with palliative care, the focus is on comfort, and with the top priority of honoring their personal preferences and choices. And by that I mean their personal and professional choices now. What are they telling us now? I may have said something when I was younger, such as I want to visit my grandmother in a care home, and she had all kinds of hairs, mustache and hairs, and I say to my daughter, if I ever get like that, you be sure you pull them all out, right? I don't want to look like that. Okay? You promise? Don't let me look like that. And you promise. So then, of course, I'm going to get old. And of course, I'm going to get menopausal, and I'm going to get all these kind of chin hairs. And I have dementia. And you come to pull them out. As soon as you pull them out, why are you hurting me? Stop. You're like, but Mom, you said it. And I start hitting, right? You might keep trying. I might bite you. What's happening here? I did indeed say, never let me have a mustache and beard as an old lady. But what am I showing you now? I can't tolerate that. I don't care about that anymore. And it's very hard, and it's a very small example that I've seen personally, of I'm the daughter, and I want to do the right thing. My mom said, please don't, it pains me to see her with that, because I know she never wanted to look like that. That would really hurt her if she knew she looked like that. But she doesn't know. And she doesn't like what we're trying to do to honor a past personal preference. So when I say honor personal preferences, it's what are they showing you now? What's comfortable for them now? They may have loved to always be in the mix of, in the middle of the action and social things, but now when they're in the midst of social situations, it's distressing. They want to go. I have to go now. They won't sit and, sit with the lunch ladies anymore. They do better by themselves. So that's the top priority, figuring out what are their personal preferences and choices, looking for signs of pain, distress, anxiety, fear, and discomfort. And pain with people who are living with dementia is very easy to miss because their bodies are not processing pain signals the same way. Not that they don't experience pain. They do experience pain, just like you and me. But the signal going to the brain and being able to decipher it and say, you know what? I think my elbow's hurting me today. I think my arthritis is acting up right here. I can't do that anymore. I might express it in another way. The baby, where's the baby? Like, what the heck is she talking about, the baby? She wasn't talking about the baby yesterday, but today it's about the baby. And I'm rubbing my elbow and talking about the baby. What am I really trying to say? And that's where it's so hard when you're trying to care for and understand what's happening with people living with dementia, because they're not able to use the same language skills that we relied on so long. That part of the brain, the left temporal lobe, is damaged, and their vocabulary, their speech comprehension, and their speech production is gradually lost over time. So we have to be detectives and look for other ways they're showing us distress, pain, anxiety, all those things. So that can be a challenge there. And to seek, I kind of talked about this a little bit, about social and physical, psychological, and spiritual needs, so that what it is in the moment. So someone who went to church every Sunday, and let's say my daughter comes and takes me to church every Sunday, it's going really well, but now it's starting, I can't sit still through the whole service, and I just want to get up and go during it. But Mom loves going to church. She was a part of the church the whole life. Maybe my spiritual need now is just for you to sit and sing a hymn with me, or say a prayer next to me. But being around all those people and driving 30 minutes to Pearl City to go to the church service, that's too much for me. I still have spiritual needs. I am who I was, but I'm different. And meeting my spiritual needs in this example requires who to make the adaptation. In our relationship, who has a healthy brain about living with dementia? Sometimes it's hard to remember because we definitely don't feel fully functioning sometimes when we're trying to help the person we love with dementia. But it's us. We're the ones who can take a time out. So here's another important hand signal everybody needs to practice: time out. Who, when we're encountering those kind of moments where we're butting heads and getting frustrated and not understanding what's going on sometimes, for us to take the time out, take a deep breath, and if you're in your comfort of your own office or living room, take a few breaths to be able to step back and see what are they showing me? And I ask people to try and be kind of old school detectives, like police detectives or Sherlock Holmes detectives. What are you seeing? Like, what exactly are they doing? Is she, she's rubbing her elbow, right? What is her face showing? Oh, it's grimacing. What are the words? Where's the baby? Okay, there's no baby. She's 85, but that's like an anxiety thing. So what is this? Putting those little clues together to come up with my lifelong arthritis in my elbow is acting up takes that kind of detached detective work sometimes. So at this stage, because it's a stage of acceptance, of letting go. Here, this is another important hand motion: letting go of fixing, because we can't fix this, and it's going to take some grieving as well. That we can't turn the clock back on the dementia. All those things on the first health promotion screen, the changing your diet, watching your numbers, all those things, those are great. By the way, for all of us, the time is now. Time is now to make those kinds of changes. But when I'm 85 or 90 with mid-stage dementia, adding vitamin supplements and changing me to, let's say, vegetarian diet is not going to change the outcome for me. Like, it's not going to, all forms of dementia are terminal, and there is not any fix for them. So in terms of comfort care, what do I need now? And move to let go of that and to move on to comforting. It can be a really, really hard thing. And for us as professionals, hard to help guide the family to that point. And in some people never get to that point. And it's a very, very individual situation because there, like I said, there is a lot of grieving. And in the course of the change of the disease, it becomes harder and harder for families to see the person as the person they loved before, because we're very fixated on who they were. And it's hard to see them in who they are now. So if you think about for yourself, so think about, okay, so we're going to think about someone who's living with dementia and their adult child who's their caregiver. So if you think about your own parents, right, your own parents, what point in your life where you have the strongest need for comfort and strongest loving physical connection to your parents, right? When is that? When you're a very, very young child. The bond is so tight. And that time in life is how there's two times we have the strongest memories of our parents, right? One is what they were like to us when we were little, because that's the positive bonding time. And then there's this time, the breaking time. What part of our lives do we, not all of us, but I have to admit I did it, yell, I hate you, don't tell me what to do, like teenage years, right? You don't understand anything, right? Because we're naturally trying to separate from our parents. And that vision of our parents is how we often still see them. And so when we have, again, I'm back to the 85-year-old mid-stage dementia, that's not my mom. My mom never wore muumuus. She always wore pants. She was a woman on the go, and now I see her in this dress. Why is she wearing a muumuu? Because she can't manage the pants, and she's incontinent, and it's hard to meet her care needs in not a dress. But letting go of that image I had of her before is really, really hard. The other one for spouses, it's extra hard as well, because again, the bonding and the breaking, the image, and I have to say this is true for myself too, you know, and for my own self-image. The image of my husband in my brain is about the age we got married. You know, even though I don't think he's on this webinar, doesn't have any hair anymore, I still see him that way. So if I had dementia and I was looking for my husband, I might not recognize him as he is now. Right? But even for us without dementia, I'm looking at my wife. I can't see her now because she is so strongly fixed in that earlier time. And the other strong emotional memory, because emotional memory is going to a different part of the brain, divorce. That's the flip side of that one. So there's a lot going on, and it's not so simple to say, you know, a family is in denial. They think they can keep fixing this. If you just give her more coconut oil, you know, I think this is going to help. And you as the professional might know full well it's not going to help. But there's something more underneath it. They're losing the person they love. They're having trouble seeing the person that they love at all anymore, and they want it back. And that's perfectly normal, but it's really, 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 really hard. So we can change how we comfort, right? But we can't change what's happening. So I want to pause for a moment and look at acute illness versus dementia. So we looked at all the previous methods of care, from curative, restorative, maintenance, compensatory, all focus on the things you can fix. So you can fix it, it gets better, it goes away, it lasts a short time. Doctors know what to make it better, and the person's expectation is to go back to how they were. The dementia side, you can't change it. Keeps getting worse. It lasts years, and doctors can help, but they can't fix it. A lot of times, a lot of the help that doctors, or not just doctors, all medical professionals can give are to the families who are trying to support the person living with dementia. And you can't go back. The person is not the same, but they are. I want to emphasize that They're not a stranger. They're not a totally different person. They are who they were, but they're experiencing brain changes. Right? They're still there, but they're different because the way they perceive the world has changed because of the changes in their brain. So I want to do a quick overview of these are the traditional words that are used for early, moderate, middle, severe, profound, and little kind of overviews of what each one. So in the early loss, I might have trouble unless things are always the same. Like, okay, if I go to the senior center at the same time and I sit next to the same person, everything's good. But if you try and put me in a different seat, Lord help us all, because I'm going to have a meltdown. Moderate loss, moderate, I'm going to kind of lump moderate and middle. I might be more hunting and gathering. I might be making more mistakes. As we progress further, I might be on the go all the time, or I might just be like conked out all the time. And profound loss would be close to end of life, where I've lost more mobility and I'm kind of stuck in time. So when we're working with our own selves or our own families or with other people that we're trying to help, how do we know when it's time to let go, and how is that different than giving up? Because I'm not suggesting giving up and just, okay, well, you know, it's terminal, we don't have to do anything. You can just stop feeding her right now because it's terminal. That's not what I'm saying at all. We're looking for, how do you know when it's time, and what kind of things can we do? So here's the things that you'll start to see. The cost, and by cost, I don't mean the monetary cost. I mean like the physical and emotional cost versus the benefit to the person. So the struggle, for example, of trying to get my mother to eat. I try and get her something to eat, and she won't open her mouth, and we start to struggle, and she might spit it out, and I might start to cry. And please, Mom, please, just one more bite. You know, oh God, she's lost 10 pounds in the last month. Just one more bite. That tension and that crisis between us at every meal, is that worth the few calories that are go in? Even if I were to eat some, it's still not going to change the outcome. How many of us would like to have those be the last words that we heard from the person that we love, as opposed to, oh, Mom, you don't want any more. Okay, I'll be here with you. I'm here together with you. Or would those be the final words you would want to hear? We want to figure out what's possible versus what's probable, and what is the best case outcome, and is it worth it? So, you know, if someone is in the later stages, mid to later stages of dementia, and has a cancer diagnosis, what's the best case outcome from having surgery and chemotherapy or other kinds of cancer therapies? Is the physical discomfort and the person pulling out the IVs and things worth the final outcome? Does it really change the final outcome? Also, what did they tell you before? So many people, of course, some people don't, but many people do have their advanced directives, and even though they're living with dementia, I can't tell you now, is there some documents or did they tell anyone what they wanted? And the last one is this about them, about you, or about someone else? A lot of times it's hard because we need them so much, and it's hard to let go, and they stay for us, they love us. But when we are able to let them be who they are in the moment and realize have them know that we are there to support them through the very end of their journey, that's when we can really connect and find those moments of joy together. So I want to take a quick look here at the brain scan. So the picture on the left is a normal brain, and it's sliced as if it's sliced like this. Two different slices, same brain. The top is the frontal lobe, the back is the occipital lobe. And you'll see all the way through late Alzheimer's. And so you'll notice, well, what do you notice? You notice a lot of change in the amount of red, which is the most active glucose burning part. And then at the late Alzheimer's and you look at the child's brain, that 18-month-old child's brain, very, very similar sections. That's the primitive brain, the amygdala, a little bit on the occipital lobe in the back there. So on one hand, you look at the normal brain on the left, and the late Alzheimer's, this is right before passing. You think, gosh, look how much is lost. There's like nothing there. I'd like to flip that and look at the child's brain. That's an 18-month-old child. And think about any 18-month-old child that you know. We don't look at them and think, oh, wow, poor thing. Yeah, they just can't do anything. They can't talk. They just eat with their hands. Ugh, that's terrible. Poor thing. We never think that, right? Because we know that they're going to grow out of it. But this person has grown in the other way. We don't think of a child with lesser abilities as a lesser person, or any less of a person than they're going to be when they're 21, 22, or older. In the same way, a person in late-stage Alzheimer's is who they were, but they're different, and they're still human beings with a core self and needs and a desire for love and human connection. They can't express it the same way as you and I do now, or that they did before, but they are still there. So I'm going to go forward a little bit. Make sure we have enough time. I'm going to go forward here. So look at the signs that it might be time. The signs that it might be time to be moving towards palliative or hospice care. And one of the big ones I mentioned in the beginning is the repeated infections. So not only do you get repeated UTIs, who might not respond or just like come right back, then you get the consequence of those repeated UTIs. You get the diarrhea, you get the excoriation, right? You might get a number of other things that you might get dehydrated, and then you land in the hospital. So that is one definite sign. Antibiotics seem to be ineffective. Refusal to eat, holding food in mouth, spitting it out. One of the first things that starts to be rejected are proteins. So I'll chew my meat, and then I'll spit it on the floor. I'll put it on the plate. I had a lady who would take out any meat and chew it up and put it in a little circle on her plate. That's one of the signs that they're not able to process those proteins anymore. They can't take it in anymore. A lot of fevers, primitive reflexes show up. So you start to see more contractions. If they still have language, they might talk more about saying goodbye or going home, right? They can't keep weight on. Even if they're eating like champs, they're still losing weight. So it's going right through. Their body is not able to absorb it. So this is the very end stage, and I want to show you, Teepa Snow, who developed the positive approach to care, has and we did a different webinar on it, the different stages illustrated as gems, and the last gem is a pearl. So if you take your hands like this and think of an oyster, this is your oyster shell, hidden and quiet, right, closed up, beautifully layered, and if you open it up and look inside, there's a beautiful pearl. But if you think of how hard it is to open an oyster to get at that pearl, it's really, really hard. So at the very end stages, they're ruled by reflexes and contracted, and it's hard to get in there. If you try and uncontract them, painful, right? Because my muscles are all on and I can't uncontract them. So I want to show you a short video of a lady whose name happens to be Pearl. I think I've left just enough time. It's a little 5-minute video, and this is Teepa Snow talking about how to connect with someone who is in that very, very late stages. So that brain you saw in that PET scan that was similar to the 18-month-old child's brain, this is the stage that we're going to be looking at and seeing that person, how to connect, still being quiet, slowly, and using those primitive reflexes that are still there to connect in that moment. Okay, so I'm going to screens here. Let's practice doing this before we come on. Okay, and I'm going to press play here.
This is a lady at the very, very end of her life. Her name is Pearl, and that's actually my gem name for this level, which is just so all came together. It's just how it is. And I want you to look at my lady for just a minute, because I want you to realize that she is truly an amazing lady. And what I will do is share at the end a little piece of information about her. Here she is. She is down to nothing but skin and bones because her brain has already used up all the protein it could find. And where's there a lot of protein in your body? In your muscles. And so what it starts is eating your own muscles. It will consume your own muscles. And so they have muscle wasting. And they do that because their brain is going, I need protein, I need protein. And when it can't find any, and the first thing you'll notice is they start to spit the meat back out. They can't chew it. And that's because they're losing their fine motor skill. But by the end of the disease, it doesn't matter how you present the protein, there's not quite enough. Okay? So this is my friend Pearl, and I want you to watch her interaction with me. Pearl, no obvious reaction at all, is there? Pearl, 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6. Hey! It took her 6 seconds to realize I was there, from the call of her name until she found me. That's how long it took her brain to go from a sound, her name, oh, it's somebody calling me, they were over there, I should look. How often do we give people that much time to recognize that we're coming? Yeah. It's Tifa. I'm going to help you get up and get washed up. Okay. All right. Connected? Put the rail down. Yep. Notice I keep hold on her when I'm moving around so I don't lose her. I want the shell to close. Let's take the cover and put the cover down. Take a look at her legs. Good. That's it. She can't straighten them out. Muscles have drawn up. Take a look at her feet. They're purple. Circulation is failing. Okay. All right. Now, first of all, I'm going to put on your socks. I'm going to put on your socks. Okay? And here we go. I'm going to turn the sock right side out. Does she comprehend my words? Not necessarily does she pick up on my tone of voice and know that I'm about to do something, and notice how I'm sliding my hand down her leg to get to the foot. Foot. Look how purple it is for circulation. That's it. Systems are shutting down. She won't heal the wound down there anymore. Okay. And I'll bring the leg up and in. There you go. Up and put it down. In. Good job. All right. Good work. How's that? Pearl, I have a washcloth for you. I'm going to help you wash your face off. I'm going to help you wash your face off. That's it. Let me see your hands here. Good. Now, here we go. I'm going to wash your face. It is one, isn't it? Let's do your cheek. Now, people think she's trying to eat the washcloth. It's a primitive birth reflex called a rooting reflex. I touched her cheek, she's turning to the nipple. Primitive reflexes reemerge. Is she connected to me? Yeah, this is a lady, she was a public health nurse for 50 years. She's within 5 days of dying. And yet, she's right there. We have a moment to connect because I accept she is where she is, and yet she's very aware of me in this moment. And here's the reality. Up until the time I cared for her, they said she'll scream like crazy when you try to do anything with her. Did she scream like crazy? No. Why do you think that might be? Because she actually understood what I was going to do, and she got what I was doing, and it didn't scare her. Now, the very last thing I want to show you.
Okay, I'm going to pause that there. I love that lady, Pearl. So I wanted to pause here and end on the Pearl and end on the real Pearl of the woman. And it really is so moving to me to see, to be able to see the person inside and to see them be able to make that connection, even though they can't communicate right exactly the same way, even 5 days before passing. So I want to pause and open it up to questions. Jody, if there's anybody who's put any in the chat box, or if there's any, I'll let you lead the question part.
Yeah, I don't see any questions in the chat box, but certainly we have been muting you guys when you call or you log on, so you can unmute yourself on the bottom. If you scroll your cursor down and you want to ask any questions, you can just unmute yourself. And do you have anything to ask Dorothy? Anyone? Or you can chat the question to her. Maybe not. But there was just something about the pain, you know, and not being able to express the pain, and how important it is to know if that person has arthritis. Right. You know, because then later on, as they progress, they will not tell you. It doesn't even, they'll only look like they're cringing. Right. And it reminds me of even, you know, when dogs have a lot of pain, they pace. They pace. And it's just these signs of how to identify pain. And especially if it's something different, you know, so if pacing is not the person's normal behavior, then what is it telling us? So it tells us, oh, they seem restless, so what's behind that? That's the question, yeah. And it's the other thing that we run into for the challenge in diagnosing pain with people with dementia is our traditional way of doing it is, Jody, are you having any pain? No. So I'm using my words. She's not understanding my words anymore, but what does she see me do? Like, no pain, no pain? She actually has a lot of pain, but she's copying my visual cue. We sometimes don't realize how much we're telegraphing when we're asking a question. And it happens in doctors' offices too, you know. So they're not stupid. They have dementia. They're intelligent people. They just are experiencing brain change, and they get our visual cues that we're giving them sometimes. Like, no pain, feeling good? Yeah. Oh yeah, I'm feeling good. But I might really have an undiagnosed source of pain. Yeah. There's just excellent information. There's just a comment about no questions at this time. Okay. But the other thing is the way that it can linger. Somebody can be in and out of hospice for years. Yeah. In this pearl stage. Yeah. Yeah. You can, or not everybody, even though I didn't cover the gems in this one, not everybody goes all the way, like even that early, middle to profound loss, not everybody travels the full length of the course of dementia. Some people pass away mid-stage from other conditions. You know, let's say you might have a heart attack or diabetes or something that might bring an end to your life other than dementia. Yeah, you can linger in any of the stages for a long, long time. And what can be hard for families is it seems so bad at that point. It's like, how much longer can this go on? And it's not that they're bad people, but it's hard to wrap your head around how long it can take. And you're right, someone can, sometimes you might hear it called graduate from hospice. You can be in hospice. People actually live as long or longer under hospice care than they do without hospice care. So a lot of times people have the mistaken impression that, oh, you go on hospice and then you die. No, not necessarily. You go on hospice, you get excellent compassionate palliative care. You can live quite a long time on hospice care. It's not a kind of a pull the plug situation. It's an acceptance of things. Even if we did other kinds of care, all those other earlier cares, we looked at those slides, it's still not going to change the outcome. The other thing is, we just wanted to, I'll send everybody an email. If I don't have your email, please call me at 295-2624 or email me at jmishan, MISHAN, @hawaii.rr.com. Some of you I don't know that have logged on. But we wanted to mention that there is a wonderful hospice and palliative care organization, Kokua Mau. I see Jeanette Kojane didn't call in today, but Lori, I'm wondering if you wouldn't mind, Lori Protzman, announcing about your workshops that you give on advanced care planning.
Right. Hi, Jody. Yes, I do have an 8-hour workshop, and I'll get the dates for 2019 up on the website. It's a free all-day training for professionals on how to have the conversation, the difference between pulse and advanced directive and the like. Happy to move those dates to you, Jody.
Thank you so much.
Thank you.
We'll send a link, we'll send you all the info, but I really need to know who you are, because those of you that logged on, I may be seeing only a first name or maybe a phone number. So I would love to know who you are so I can send the links. Kokua Mau, if you don't know about it, Kokua Mau, you can look it up on Google. It's Hawaii's Hospice and Palliative Care Organization, and they also do workshops on advanced care planning. And I might as well just announce the next one we're doing in November, November 27th. We'll be having Valisa Saunders, who is an advanced practice nurse, a gerontological nurse here at Queens, and she's going to present on polypharmacy and dementia, which is going to be very interesting. So does anybody else? Oh, okay, I see a question. Thank you. What tools are recommended to assist field workers in suspecting dementia during home visits?
Ooh.
Well,
That's your...
I know, I see, and this is coming from R. Rice, and I don't have your email either, and I would love it if you would give me your email privately in the chat so that I can send you links. Whether you're based in Oahu, are you in Oahu or on a neighbor island?
The healthcare navigators.
Yeah, we have the public health nurses are memory care navigators now that have been trained. And we have some on the phone. We have Mary Gaddam on the phone, who's a public health nurse, who has been trained to be a navigator. And they'll go into the home and do an assessment and do a screening and then recommend to go to the doctor if dementia is suspected. But R. Rice, please give me your email so I can send you tools or anything you need to assist you. And there will be other trainings that Catholic Charities Hawaii will be sponsoring on Oahu to train professionals on care coordination for people with dementia. So we would very much appreciate, oh good, so I got you, you are on Oahu at DHS. So I will definitely send you links. And DHS has been involved in trainings on dementia capability that include screening. There's a thing called an AD8, which you can look up and I'll send everybody. It's a simplified type of questionnaire. There's also the mini-cog and others, but I can send you that information. But yes, there's opportunities for training for that. Mm-hmm. Thank you for that question.
That's a great question.
Anyone else? I guess that's it then. And thank you. Happy Halloween to everybody.
Happy Halloween, and thank you so much for all you do for people living with dementia and their families and supporting each other as professionals. Thank you.
And Dorothy, thank you so much. You're an absolute gem that we have in Hawaii.
Yeah,
thank you, everyone.
Okay, take care. Bye. Boy.